Just want to say welcome, everyone. My name is Christina Clayton. I'm one of the co-directors of the Northwest Mental Health Technology Transfer Center. Welcome to today's webinar, Co-Occurring Disorders, Compassionate Care for Healing and Recovery with Elizabeth Black from C4 Innovations. Want to also please, take a moment to reflect on the lands on which we reside and work. We, do this land acknowledgement to really acknowledge the ancestral homelands and traditional territories of Indigenous peoples, past and present, who have been here since time immemorial. And we always want to learn how to be better stewards of these lands through action, advocacy, support, and education. And if you haven't heard of the link Native Land, it's in the chat now, and it's a really fantastic resource if you want to learn more about your lands. A little bit about our Mhttc network. It is a nationwide network, if you haven't heard of us before, that is supported by the Substance Abuse and Mental Health Services Administration, or SAMHSA. Our network includes 10 regional centers, a National American Indian Alaska Native Center, and a National Hispanic and Latino Center. And there are similar structures for the addiction field and prevention field. We support resource development, dissemination, training, technical assistance, and workforce development for the mental health field. And our specific MHTTC covers the Region 10, which includes Alaska, Idaho, Oregon, and Washington, though I can see many of you. I do see some folks from our areas, but also with this virtual world, we're everywhere. I did want to just stop for a moment because I realized I didn't acknowledge the poll. Maybe we can share the results at this point. Thank you for participating. It's always nice to see who's in the room. It's a wide smattering as usual, a lot of others. So thank you for putting your specifics into the chat. Workforce setting, workplace setting. Again, this is general. It's great to see some shelter and housing folks out there as well. And then what is the primary population? Yeah, I mean, some people may not work with both clearly, and yet we know most of the time it's both and more. So thank you so much for answering that, and we look forward to talking with you soon. Okay, so I am going to move on to our specific center is based at the University of Washington Department of Psychiatry and Behavioral Sciences. And our area of focus for the network is evidence-based practices for serious mental health issues such as psychosis. So that could be assertive community treatment, cognitive behavioral therapy for psychosis, integrated care. But we train on a variety of topics, including suicide prevention, diversity and equity issues, school mental health, peer support, trauma-informed approaches, and others. And we do that through live events such as this. We have a lot of free online self-paced courses. We have virtual learning communities and other technical and training assistance that we offer. We do monthly newsletters as well as several announcements, not per week, but maybe one or two per month for sure. So if you are interested in signing up, we'll put that link in the chat, and that way you can know about events and potentially learning communities that we do really in Region 10 specifically. So if you want to know about that, please sign up for that. All right, so for today, you're muted, you're off camera, it's a large group. We do share the recording and slides and send instructions in a week or two on how to obtain a certificate of attendance in a few weeks, potentially at worst. But we do have the recording. We'll have a highlight document with the key points. And so those will be available in a couple of weeks, if not sooner. For today, and I think this is pretty common, please use chat for technical issues, just saying hello, that sort of thing. Q&A needs to be for when you have a question for Elizabeth. And so what we're going to do is she's not going to be able to see chat while it's going by or look at Q&A while she's doing her presentation, but I will be in the background looking for your questions, throw them in anytime, and we'll try to facilitate as many as we can at the end of the presentation. Evaluation, it's really important that we hear how you thought this went. And so we value this so highly. It takes literally a minute to fill out this survey. And it does ask for like 2 letters related to your mother's maiden name or something like that, and a social security number. Like, these aren't going to connect to you in any way. Put whatever letters and numbers you want, but we really value your feedback, and we share that in an aggregated way with our presenters, and it really helps us know how these topics went and if we want to keep doing more of those. And of course, SAMHSA has funded our center, but they don't really have any interest or opinion on our content. So we're so grateful to have you here today. And actually, I know we did the poll already, I think, correct, Gabrielle? I think so, Elizabeth. Yeah. Okay. So I'll just get right to introducing Elizabeth. So Elizabeth, we're so grateful to have you here today. She has worked with and on behalf of marginalized populations for more than 15 years. She holds a master's degree in rehabilitation counseling and is a licensed drug and alcohol counselor. Ms. Black serves as a subject matter expert, trainer, and technical assistance provider for substance use, mental health, and recovery initiatives. Her areas of interest and expertise include harm reduction, medication-assisted treatment, and health and wellness in recovery. So welcome, Elizabeth. We're so glad to have you. Very excited to be with you here today.
Thank you. Excited to be here.
Yeah. So I'm going to stop screen sharing so people can see at least your face more than when I'm screen sharing. And we're so happy to have you here today, Elizabeth, to talk about co-occurring disorders, compassionate care for healing and recovery. And I love this topic. I love how you phrase that. And we're so grateful to talk with you. Can you share with us a little bit about your background and what path brought you here to the field and talking about these issues today?
Yeah, definitely. So I am a licensed alcohol and drug counselor and have been in the field for going on 20 years now. I'm aging myself a little bit. And so during that career, I have worked a lot with people with co-occurring disorders. Because what anybody in the field knows is where you have one, you're more frequently to have the other. They tend to show up in tandem very frequently. And then besides my professional work, working in this population, I also have my own personal lived experience with co-occurring disorders. So in my youth, I struggled a lot with undiagnosed, untreated anxiety and depression. And as a means to cope with that, I turned to substances, specifically in my case, alcohol, as a way to self-medicate. And so I know both personally and professionally the struggles that people with co-occurring disorders face, not only just within the disorders themselves, but also in the barriers that really present them getting into recovery and into treatment systems that really serve them. So I'm happy at this point in my life that I can really be an advocate for that.
That's just so helpful to hear and understand. And I know, many of us have similar backgrounds and we don't always have titles like peer specialist or recovery coach or something that indicates that we have that lived experience. And so I think that with COVID and stressors in the workforce, we know that these issues surface in the staff as well and in our field. And I don't know about you, but the stigma of seeking care when you already work in the profession, that is heavy. And so I just want to say, just as a personal shout out to anybody that, it only helps us do better in our work. And I think, trying to get over, we're trying to help people get care. And then we think of ourselves and think, oh, I don't know, I can't, or, it's
Right.
a real struggle. So it's, I'm very grateful that you shared your experience, and that just makes everything so much more powerful. So thank you for sharing that.
Yeah, because in actuality, this stuff doesn't discriminate,
Right.
It affects absolutely, I would say almost all of us in our lifetime, if not us directly, then somebody that we love.
Absolutely.
And so normalizing it, not only for the people that we work with, but also for ourselves, and getting the care that we need to take care of ourselves, because we do work in such a high acuity population. That's something that, we got to work on ourselves, really normalizing that self-care and doing what we need to take care of ourselves.
Yeah. Thank you. That's really helpful. So why is it important in your view that we look at co-occurring disorders together? I anticipate what you'll probably say, and you mentioned that, a little bit already, but what is your perspective on that?
So I think it's really important that we look at them together because they are so closely related and intertwined, and they really impact and influence one another. So somebody with a substance use disorder who's actively engaging in substances, we know that that impacts the brain chemistry. And so that in turn could trigger a mental health disorder. Conversely, somebody with a mental health disorder, it's not uncommon that folks, especially before they're getting any kind of formal treatment, they work to self-medicate. They go for what works, and what works is usually a quick head change through some sort of addictive behavior. And so because of these things are so tightly intertwined, what the decades of research and experience we have behind us now shows us is that it's really important that even though maybe traditionally we have looked at them as two different conditions, that we are treating them in tandem as one. Because if we treat one without treating the other, a lot of times we set people up for failure and relapse. So as an example, if I am using alcohol to self-medicate for an anxiety disorder, and you as a provider are only focused on my alcohol use and you're not really paying attention to the anxiety disorder, then you're essentially going to set me up for failure because we're not addressing the root problem that's driving that alcohol use to begin with. And that's really why it's so important that we work and we look and we treat these disorders together.
Yeah. Well, and I don't know about you, but a lot of times when I was doing direct services, we don't know what happened. We don't know chicken or the egg. We don't have the luxury of going back in time and understanding what caused what. And at this point, the way I've understood it, it doesn't really matter. We treat them both. We
That's
treat
exactly
them
right.
as how people will accept care in whatever way that makes sense for them and just go along. But understanding that, not being blinded to any one of these things, it's difficult. It's, you have a certain tool, you want to find that thing to use that tool on, and, you might be missing something.
Yeah.
Well, for I really love the title of this content that we're talking about today, compassionate care for healing and recovery versus, shaming, stigma, or confrontation. I just think this comes up so much.
Mm-hmm.
In your view and experience, why is compassion important when we talk about co-occurring disorders care?
I would say that's because of shame, hands down. I mean, you just mentioned that. Other brain disorders like Alzheimer's, Parkinson's, epilepsy, those we don't really view as moral failings. We understand that that is something organically going wrong with the brain. However, when it comes to substance use and mental health disorders, traditionally as a society, we don't give those folks the same kind of deference. We tend to lay fault at their feet, that if only they tried harder, or were more disciplined, or had more willpower, or were just willing to look at the positive side of things, that they could get themselves out of their position. And that's absolutely not the case. And what that narrative does, that we continue to have as a society, is it fuels a sense of shame in people that have co-occurring disorders, because it leads them to believe that there's something fundamentally wrong with them, or that there's something they're not doing right, that they're not trying hard enough, and that if they had just tried a little bit harder, that they could get on top of it. And that's just absolutely not the case. And so what compassion does is it lets them know that I see you, and I see you just as you are, and I accept you just as you are. And I acknowledge that this clinical disorder is no different than any other chronic condition. And so there's not going to be judgment. There's not going to be blame and shame. I'm going to use my compassion and my consistent positive regard to meet you where you are. And as we offer compassion and we show people that we actually see them for who they are, that shame organically starts to crumble on its own. And we start to lose those defenses that people build up so high to protect themselves, because shame is a very intensive, invasive, painful emotion. And most of us will go to great lengths to avoid it.
Absolutely. Well, and just as we wrap up, just noting having that compassion in our work and watching and witnessing suffering, these ingrained stigmas and shameful, kind of habits that our society does, really impart to us, comes up for us as staff as well. And so we can have those things, just like, racist reactions, implicit biases, all these things have been drilled into us in some way. And so I guess I just want to encourage staff who are doing the work that you will be affected by watching people suffering. And because maybe they're not doing the thing you hoped that they would do, and they're still in pain, but check that somewhere else, check those reactions and deal with that separately versus let it come out with the client, is kind of what I'm hearing you say too. But yeah, that's exactly difficult. Right. It's difficult. We're people helping people. And so it's going to affect us. So we got to take care of ourselves as well. So
that's exactly right.
Well, Elizabeth, I do think I could talk to you all day. But it has been so fantastic. I've learned so much in just a few minutes in talking with you. I thank you so much for your time.
Absolutely.
And it's been great talking with you. For everyone out there, we'll get to Elizabeth's presentation now and let you start screen sharing. And I can't wait for the rest of the presentation, even more so than I was excited before. So thank you so much. And we'll see you in a little while.
Sounds good. All right, so let me get myself up and going here. All right, does that look good? You guys can see me? Good to go. All right. So welcome everybody. It's so good to be with you today. And as the title of the webinar talks about, we're going to talk about compassionate care for co-occurring disorders. And during our time today, if I can get my mouse to work, there we go. We're going to do just a brief overview of common psychiatric disorders and a brief overview of substance use disorders. My time with you is limited. I have so much content on that, but because we are kind of compressed, I'm just going to keep it succinct. And then we're going to look at the relationship between mental health and substance use disorders and how they really impact one another. We'll also touch on risk factors that make folks more vulnerable for developing a co-occurring disorder. And then we'll wrap up talking about that compassionate care piece in the form of person-centered care, what that looks like, and really why that is a best practice, looking at kind of what are the mechanisms that make that really effective. So that will be our blueprint for our time together today. So co-occurring disorders, when we're talking about co-occurring disorders in our field, we're generally talking about a person that has both a mental health disorder as well as a substance use disorder. And what the data shows us is about half of people with a mental illness at some point will experience a substance use disorder, and vice versa. The reverse is true. About half of people with substance use disorders will experience a mental illness. And so SAMHSA estimates that currently in the US, about 8 million people meet criteria for a diagnosable co-occurring disorder. And just to give you a visual, that's roughly about the size of New York City. So it's pretty significant. And so what that says to us as providers or people that work in the field, that co-occurring disorders are the expectation, not the exception. So we're much more likely to find them together than we are to find them separated. And so because of that, we want to make sure that we are prepared for that in that way. So to get us started, I want to start talking about mental health disorders. As I mentioned, I'm going to just do a brief overview of mental health disorders. Then we'll do a brief overview of substance use disorders, and then we'll come back and look at them together. So for mental health disorders, we see there are 4 major categories of mental health disorders that we're likely to run into with the folks that we work with. And those include mood disorders. And so those are disorders where people have a difficult time really regulating their emotions. What's going on inside of them does not necessarily match what's going on outside of them. And they really have a hard time regulating those emotions or those moods. And so some common Conditions under mood disorders include things like bipolar disorder, where you've got the really high highs and the really low lows, as well as depression disorder, which takes many different forms. It could be major depressive disorder, it could be postpartum depressive disorder, seasonal affective depressive disorder. So there's a bunch of offshoots from that. Then we also have anxiety disorders. So these are disorders that are based on an ongoing stress response that is present even when there's not an imminent threat. So, you know, our stress response was initially developed in us to keep us alive back from the time when we were running from saber-toothed tigers. We don't have saber-toothed tigers anymore, but we do have a lot of stressors and a lot of anxiety in our society. And unfortunately, that can become clinical, where people just feel high levels of stress all the time, and they feel like they have a hard time gaining control over that. So some common disorders for anxiety disorders are things like generalized anxiety disorder, panic disorder, post-traumatic stress disorder is a very common one. OCD, also known as obsessive compulsive disorder, and then phobias. And phobias, I think, are fascinating because you can pretty much find a phobia for almost everything out there. In another training that I do, I kind of have a guess this phobia routine that's kind of fun, but with a big group like this, I didn't think we maybe could navigate that very well. But I will share that recently, one of my most interesting phobias I've been reading about is a phobia of gravity. That wasn't one that I had thought about before, but apparently that is a legitimate phobia, that people are scared of gravity. And so it just gets to what I was saying, that you really can develop a fear of almost anything, or phobia, I should say. Then the third group, or a category of mental health disorders, is psychotic disorders. And so the two main characteristics for psychotic disorders are hallucinations and delusions. So hallucinations are false perceptions, meaning I'm hearing, I'm seeing, tasting, smelling things that aren't actually there. And delusions are false beliefs. So delusional beliefs are usually things that could potentially be true, but they're very highly unlikely. So an example of a delusional belief is maybe the government is trying to communicate to me through television commercials on my TV. That would be an example of a delusional belief. And so some common disorders among psychotic disorders are schizophrenia, schizoaffective disorder, which are mood disorders that have some sort of psychosis component, and then delusional disorder, which is a person that experiences delusions without the hallucinations. It's just the delusions that they're dealing with. And then the fourth major category of mental health disorders is personality disorders. And these are a little bit different than the previous three. The previous three disorders are basically, for the most part, believed to be organic problems of the brain. The neurotransmitters in our brain are misfiring in a way that makes it hard for us to regulate our emotions. Personality disorders, though, are different in that they're not organic brain disease. Instead, what they are a combination of problematic personality traits that make it really hard for a person to thrive in their life in terms of things of being able to hold down a job or to develop meaningful relationships. All of those things that we know that are so important to good emotional well-being, that becomes kind of barricaded by these problematic personality traits that usually are born out of some sort of trauma. So common personality disorders that you've probably heard of or familiar with are things like narcissistic personality disorder, borderline personality disorder, antisocial personality disorder, and then paranoid personality disorder. And so when we're talking about mental health disorders, the go-to for these is normally treated with counseling, and there's a variety of different methods of counseling that are used for different disorders. But again, our time is limited today, so I didn't go into that too much. But the other important component of this is also psychotropic medication, which really can make a huge difference for a lot of the mental health disorders that we're talking about today. And one of the most common types of psychotropic medications is antidepressants. And so what antidepressants do, they are medications that work to increase the amount of neurotransmitters in our brain. And so neurotransmitters, if you're not familiar with them, are chemical messengers that our brain cells use to communicate with one another. They send these chemical messengers back and forth. And so good emotional well-being is thought to be based on a balanced, adequate supply of neurotransmitters, which make sure the brains and the cells are effectively communicating with one another. And when we run into difficulties with mental health disorders, the belief is that is because these neurotransmitters are out of whack. And so antidepressants work to correct those imbalances. And the three major neurotransmitters that we are talking about when we're talking about mental health disorders, or behavioral health disorders, I should say, are norepinephrine, dopamine, and serotonin. So norepinephrine is known as the neurotransmitter that's behind our stress response, the fight, flight, or freeze. Then we have dopamine. Dopamine is known as our reward chemical. So as part of our evolution, the reason that the body has developed dopamine is it encourages us to engage in behaviors that are important for our survival. So every time we eat delicious food, dopamine gets released. Every time we have sex, dopamine gets released. Every time we share a laugh with a loved one, dopamine gets released. Every time we engage in physical activity, dopamine gets released. And again, the reason that happens is because it's the body way of encouraging those behaviors that are important for our survival. Dopamine is also the chemical that is behind most substance use and addictive behaviors. Those are usually done at dopamine grabs because, again, dopamine is a reward chemical that makes us feel really good. And then the third major neurotransmitter that we're concerned about with behavioral health is serotonin, which they've dubbed here the love chemical. But serotonin is really the neurotransmitter that is behind regulating our mood in a stable way and creating emotional stability. That's really serotonin's job in our brains. And so some of the most common types of antidepressants are known as reuptake inhibitors. And I really want to do just a kind of brief review of what this is, just to give you guys some understanding of the mechanism of action for antidepressants, to kind of take some of the mysticism out of it. So as I'm doing this, I want you to look at this image I have here on the right side of the screen. And this represents two brain cells, brain cell A at the top and brain cell B at the bottom. And so what happens in the brain cells communicate is brain cell A starts releasing neurotransmitters. In this graph, for the purposes of the day, it says serotonin. But you can see the serotonin is being released on the left side of the cell. And it gets released into the space in between brain cell A and brain cell B, known as the synapse. And brain cell B, you can see there, has receptors on it. And those receptors absorb the neurotransmitter or the serotonin that's being released. And when they absorb the neurotransmitter, then the communication is complete and we have good emotional functioning. Then what happens, just as a natural part of the process, is the unused amount of neurotransmitter gets reabsorbed back into brain cell 1. And so when we have mood disorders, anxiety disorders, the belief is that that reuptake process where the neurotransmitter gets reabsorbed back into the cell happens too quickly. And because it happens too quickly, brain cell B doesn't have enough time to absorb enough of the transmitter to complete the communication. And so communication breaks down, and that's where we get into emotional dysregulation. And so what antidepressants do in the form of reuptake inhibitors is they stop or slow down the reuptake process that you see on the right side of the cell here with the blue ball that has blocked it. And so when we block that reabsorption process, it makes more of the neurotransmitter available for longer, giving brain cell B more time that it needs to absorb the neurotransmitter to successfully successfully communicate the communication that's coming through from the neurotransmitter. So you'll see we have 3 major types of antidepressants. The first one is SSRI, and that stands for selective serotonin reuptake inhibitor. And so those medications, which are like your Paxil, your Prozac, your Zoloft, they work on this process for serotonin. So they work to make sure there's more serotonin available in the synapse. SNRIs, which are your Effexor, Prestique, Cymbalta, those are some of the more common SNRIs. They work on this procedure for the S being serotonin, and then the N, you can probably guess, is the norepinephrine that we were talking about, okay? So it works on this process for both serotonin and norepinephrine. And then the last one we have is NDRI. And so again, thinking about to those 3 major neurotransmitters, you can probably guess that refers to norepinephrine dopamine reuptake inhibitor. And we actually only have one NDRI up to this point, and that one is known as Wellbutrin. So if you're familiar with Wellbutrin, also marketed as Zyban for folks that are trying to quit smoking, you'll know that its mechanism works a little bit differently in that it creates more dopamine and norepinephrine available for the brain cells to communicate. Okay, so hopefully that makes sense. That's kind of just a layperson's version of what antidepressants do and how they work in the brain. So now let's move to talking about substance use disorders. And to get us started here, I have a short video that I'd like to share with you. You may or may have not seen it. It's called Nuggets, but I think it does a really wonderful job of kind of showing what the progression of a substance use disorder looks like. So let's go ahead and watch that now. Let me make sure I got my sound on here. All right. So we'll watch that now, and then we'll come back and pick it up afterwards. So I really love that video because it's so simple, but it's so succinct in kind of demonstrating what the journey of substance use disorder really looks like. And it's very powerful. And I also like that it reminds us that nobody really actually ever starts out to have a substance use disorder. Usually it's something, that eventually evolves. None of us wake up in the morning and say, I want to grow up to be, addicted to heroin or whatever. But it's usually a process that people go through where they end up finding themselves in these situations. And so again, getting away from the blame and shame of it all, that's so huge as a part of this. So we see that there are four main categories of substances that we contend with. And those are opioids, stimulants, hallucinogens, and depressants. Most all substances will fall in one of those four categories. Here, this shows you, tells you a little bit about what each one is, gives you some examples of different substances that fall in that category, as well as some common street names. And the street names are always changing. It's kind of hard to keep up with. But when we're in the field, it's kind of good to keep your ear to the ground, know what the street names are, just so you can have a conversation with folks about them, right? And so the question really becomes, when does substance use go from recreational to disordered? That's the question that we're getting at here. And I would say informally, the threshold for that is when it starts causing problems in a person's life. That's really kind of where we measure when it starts becoming a disorder. The DSM, though, to try to make it a more formal assessment, they came up with this 11-question questionnaire that is now used to diagnose substance use disorders. And so the 11 questions look at, do you have impaired control? Are you taking more than you intended to take? Have you tried to stop using and have not been able to do so? Are you having cravings that are driving your want to use? It also looks at social problems. Are you neglecting primary roles in your life because of your substance use? Is it causing problems with your relationships? It also looks at high-risk behaviors. Are you knowingly putting yourself in dangerous situations in order to be able to use? And are you using despite knowing that there are physical and psychological consequences that you're dealing with? And the last two questions look at the pharmacology of substance use disorder, referring mainly to tolerance and dependence. Are you having to take more of a substance in order to get high? And have you become dependent on the substance? Meaning, if you don't take the substance, do you start to feel sick or ill? And so depending on your answers to these questions depends on if the severity of your substance use disorder. So if you answered yes to 2 or 3 questions, then you're considered to have a mild substance use disorder. If you answer yes to 4 to 5 questions, you're considered to have a moderate substance use disorder. And if you can answer yes to 6 or more of these questions, you're considered to have a severe substance use disorder. Now, this is not to say that if we don't have licenses, it's not within our professional wheelhouse that we're diagnosing people. But I instead just want to give you an idea for those that may not know of how we come to a decision whether somebody has a substance use disorder and the severity of what that substance use disorder looks like. And what we see for treatment of substance use disorders, there are 3 major elements, and SAMHSA calls this the 3-pronged stool, or 3-legged stool, I guess you would say, and how they talk about how if you don't have one leg of the stool, it creates instability. And of course, recovery We're wanting stability. So it's really important that we have all three elements when we're talking about substance use disorder. And so that includes the behavioral interventions, where we're talking about things like counseling, peer support, where we're starting to address maybe trauma that's driving the behavior. We're starting to talk about new, more productive coping skills. We're helping folks identify problematic thought processes and behaviors that really continue to engage them in their co-occurring disorder, their substance use disorder. And then the second leg of the stool is recovery support services. So that looks like care coordination, also known as case management, where we're kind of looking at what are the holes in their foundation of recovery, and how can we work to plug those holes for them. So for instance, maybe they're using because it's COVID and they lost their job as a result of COVID. And now they're stressed about money and they've got way too much time in their hands. And so they're sitting at home, bored and stressed, and they use substances as a mean to escape. In which case, part of our care coordination may be, linking them to employment services or vocational rehab, or connecting them with educational resources where they can learn a school or trade. Recovery supports can also look like skill building. Doing things like relapse prevention, looking at developing new coping skills and that kind of thing. And then the third leg of the stool is medication. And this is specifically for, to date, alcohol and opioid use disorders. So here on this slide, you can see the medication. I have the opioid use disorder medications, methadone, buprenorphine, naltrexone. But know that we also have medication for alcohol that seems to help as well. Other substances, stimulants, cocaine, meth, there are medications that they use as part of detox, but they're not these kind of ongoing take home with you medications yet. Though there's always new meds in the work, and I'm hoping as we move forward, we'll start to find more and more medications available for different substances beyond just opioids and alcohol, which is really kind of what we have for right now. Okay. All right, so that was my down and dirty versions of both mental health and substance use disorders. So now we'll move on to talking about these together, where in one person they're known as co-occurring disorders. And so Christina mentioned this earlier in our chat at the beginning, where we talk about, which comes first, the mental health disorder or the substance use disorder. And it's really a little bit of the chicken and the egg, because we don't always know what comes first. Establishing which came first or why can be difficult as they influence one another. So, somebody who is abusing substances, that may contribute to a change in their brain chemistry that could trigger a mental illness. And somebody with a mental illness may use substances in order to be able to cope with the symptoms of their mental illness. That was like my experience, right? And so they're just so tightly linked together. And additionally, they both share common risk factors, which we'll talk about earlier, or we'll talk about a little bit later. And so to know which risk factor triggered which disorder, I mean, it's just not clear a lot of the time. And the good news is that establishing sequence is not necessary. That's what the research has showed us, because what is necessary, what does see the best outcomes, is making sure that both of them are treated simultaneously, regardless of which one showed up first. We don't even have to worry about that. So that's the good news, especially because it's so difficult to tease out so much of the time. And so when we're talking about risk factors for co-occurring disorder, of course, the ongoing question is always, is it nature or is it nurture? And of course, the answer that we almost always arrive at is that it's both. And so we'll talk about that next. So when we're talking about risk factors for genetics, like any other chronic health condition, genetics contribute to the risk of developing a co-occurring disorder. So if somebody in your family has a history of mental illness or has a history of substance use disorder, you are going to be more vulnerable to developing one or both of those. Just in the same way that if we have a family history of hypertension or diabetes or of cancer, we're more likely to develop those, right? In NIDA, the National Institute of Drug Abuse, in the research they have done, they estimate that up to 60% of a person's vulnerability to addiction is attributable to genetics. 60%. And I think that's so powerful. And I think that's something that we really need to share with folks that have a substance use disorder. Because again, the narrative is so often that this is a moral failing on their part. And if they just had more willpower, then this wouldn't be an issue. And that's not it at all, because more than 50% of their risk of developing a substance use disorder is completely out of their hands. Something they were born with that they have no say over. And that's very empowering to know as a person with a substance use disorder. And so genes may impact our risk as when a protein determines if we find a substance pleasurable or not. So for example, there are some people when they take opioids, they think, oh dear God, this is amazing. Where has this been all my life? Give me some more of that. Compared to other people who take opioids who just get hot, itchy, and nauseous, and they think, oh dear God, do not do this to me again. And you can tell that those are just two very different biologies responding to the same substance in different ways. But you can see how one would make a person much more vulnerable to developing a substance use disorder than the other one does. Because if you don't like it, you're probably not going to go back for more. Genes also impact our risk as our neurobiology determines the level of neurotransmitters in the brain. And so as we've already talked, the amount of neurotransmitters in our brain is what determines good emotional regulation. And so if we are off balance, then a lot of times we will turn to substances or some sort of addictive behavior in order to compensate to make ourselves feel better. I was in a conference not too long ago where they were talking about one thing they are finding with generational alcohol use disorder in families is that there's a deficit of serotonin production that is being passed down from generation to generation. And it's actually the coping skill that is being passed down instead of like this idea that there's an alcoholic gene. But instead, it could potentially be that the serotonin is not sufficiently produced in these families, and how we cope with it. That's the nurture part that we learn from our parents and they learn from their parents is, you know, we get alcohol and we have a good time on the weekends or that kind of thing. It also, our biology also determines how we respond to stress. And if we're somebody that tends to be high strung, high stress, we're also going to be somebody that's more likely to reach for substances in order to be able to cope. So again, those are just three different ways that our neurobiology can really impact the development of a co-occurring disorder. And then of course we have the nurture part of it, which is the environment that we live in, that we grow up in. So factors in a person's environment can increase their risk of developing a co-occurring disorder. And so this can include things like socioeconomic status. We know people that have low economic status that live, have higher levels of poverty, tend to struggle a lot more with co-occurring disorders, specifically substance use, because there's a lot of stress associated with being poor. Also having access to healthy foods and physical activity. It's those social determinants of care that really come into play. If you have early access to substances, what we find is folks that start early in their adolescence with substance use are more likely to develop substance use disorders into their adulthood. And then your peer group, it may be that you're more likely to experiment and develop a substance use disorder if you're hanging out with the jocks on a Friday night versus the chess team on the Saturday morning. Although I don't know, I've heard the chess team can get kind of rowdy too, so who knows, but it could be. And then perhaps most impactfully is exposure to abuse or trauma. And that's something that we have really come to understand over the past 3 decades. That really started with the ACE study. If you guys remember, if you've heard about the ACE study, the Adverse Childhood Experiences study. And that was the first time we really started connecting trauma, especially early in life, to poor health outcomes and behaviors later in life. So people who experience physical or emotional trauma are at greater risk for mental health and substance use disorders. And that makes sense because whenever you experience trauma, there's usually lingering effects in terms of like post-traumatic stress disorder or anxiety. And if we don't have somebody there at the ready to help us cope with it in a healthy way, then we're typically going to reach for the first thing that's available that works the best. And that's usually substances or some sort of addictive behavior, right? And so what that says to us as providers is that what we perceive to be bad decisions or coping skills are actually survival skills to numb and avoid probably unimaginable pain and trauma that they've gone through. And what it also says to us is to attempting to stop substance use without addressing the underlying cause will set the clients up for failure. As I was talking about earlier, if I have an anxiety disorder and I'm using alcohol to cope with it, and you're only addressing the alcohol and not the anxiety, you're going to set me up for failure because the problem of why I'm using is still there. It still remains. And so it's also a reminder to us that addiction is frequently a symptom and not the problem itself. Addiction is kind of smoke to the fire. It lets us know that something else is going on that we really need to attend to. And this is why trauma-informed care is so important. And we'll talk more about that in just a minute. All right, so now we're getting into the meat of what we're talking about today, which is really how do we offer compassionate support for folks with co-occurring disorders. And what we find is people with co-occurring disorders tend to have symptoms that are more persistent or severe than people that only have one disorder. And unfortunately, we see all sorts of negative outcomes associated or tied to co-occurring disorder. People with co-occurring disorders see higher rates of relapse, higher rates of hospitalization, homelessness, incarceration, infectious diseases, all of those things that we don't really want to see. And despite that, what the data tells us is that over 90% of people with co-occurring disorders receive treatment for only one disorder or no treatment at all. And of course, that's obviously concerning because we know best practices are that we are treating both disorders together in tandem at the same time. That's where we see the best outcomes. So what is going on here that folks that, only 10% of folks are really getting both of those needs met? Well, part of the problem lies in the way our treatment system has been set up. And so I'd like to take just a minute to review some treatment approaches, past and present, to where we are today. So when we first started embarking on treating co-occurring disorders in modern day medicine, say probably the 19th century up to today, we started with a single model of treatment. And so with the single model of treatment, what the belief was is that all substance use was due to an underlying mental health condition. And if we treat the mental health condition, then the substance use will resolve on its own. And of course, what we found is that didn't work. That was not necessarily the case for everybody. So then what we did is we moved to the sequential model of treatment. And so with this one, we acknowledge that, okay, yeah, we have two separate disorders here, and we do acknowledge now that they both need to be treated. But what we're going to do is we're going to treat one and then the other. And of course, that didn't see very good outcomes either, because we know that they're so tightly linked that they influence one another. So then we said, okay, let's try this again. And we moved to the parallel model of treatment. And so with the parallel model of treatment, now we're acknowledging that both disorders need to be treated at the same time. But unfortunately, we tend to do it in two different treatment systems. So we'll go treat your mental health disorder over here in this treatment system, and we'll treat your substance use disorder over here in this treatment system. And of course, that creates all sorts of problems in that it creates disjointed treatment. There's not one comprehensive treatment team, and a lot of times the left hand doesn't know what the right hand is doing, and we can see there's a lot of counterindications that can come up. I saw it a lot when I was working at an MAT clinic with people that were coming in on methadone, Suboxone, who would have legitimate prescriptions for benzos because they have a psychiatrist that's treating them that doesn't know or recognize that they are also at an MAT clinic. And we know that that can put them at high risk of overdose. And so that's just one example of my own personal experience of how the parallel model of treatment really breaks down. Unfortunately, it's the model that a lot of us are still in today. But where we want to be, and what SAMHSA names as a best practice, is the integrated model of treatment. So with the integrated model of treatment, we're talking about one competent treatment team at the same facility addresses both the mental health disorder and the substance use disorder at the same time. And so again, that's the gold standard. That's what we're all moving towards. But until we really get there and fully integrate it, what that means is a lot of us are working in siloed systems, okay? And so what that means for us in our role is that, one, if we're in a siloed system, it's important that we recognize and refer for the other disorder that we are not working with. So if we're in mental health, we need to make sure we know to recognize substance use disorders and know who to refer them to so they can get that treated. Or if we're in substance use, when we start to recognize some mental health disorders, we need to know what those are and who to refer people to, so that way they can get those, they can get them treated at the same time. It's also important to know what resources are available in our area and develop relationships with partner providers, so that way we can do warm handoffs back and forth. We've got the mental health taken care of over here. You've got the substance use taken care of over here. And so now when we find people that have co-occurring disorders, we can work together to meet those needs. And so we also want to make sure we are coordinating care. We're getting those releases signed. We're having ongoing conversations with our partner people at the different organizations, so that we were having one comprehensive treatment plan and treatment team to best support the people that we're working with. And we want to make sure that we're monitoring symptoms of the disorder that may not be our expertise, and making frequent inquiries on symptoms and concerns. So that way we can share with the other providers that we're coordinating core. If we notice, say, Billy is all of a sudden starting to act very manic and starting to have pressured speech and is really struggling to calm down and focus. If I'm a substance use provider, I can call my mental health provider and say, hey, it looks like Billy has some issues of mania going on here. Can we refer to you? Can we coordinate care with this, something like that? And then we want to make sure that we're including goals for managing the co-occurring disorder in the treatment plan, because we want to make sure that it stays front and center, as well as our primary, for substance use. We want to make sure that we're also including mental health goals as well, and vice versa, because we know that's so important to getting them the stability they need for long-term success. And the last thing I will just say here is to make sure that we're offering person-centered care. Earlier I was talking about the shame associated with substance use disorders, with co-occurring disorders, with mental health disorders, and person-centered care really works to help erode away a lot of that shame. So when we're talking about person-centered care, we're talking about a collaborative process where clients participate in the development of their treatment goals and services provided to the greatest extent possible. And they're really in the driver's seat. What they want to work on, what's most important to them, is really what we want to honor and partner with them to work on. So person-centered care is strengths-based, and it's focused on individual capacities, preferences, and goals. So it's highly individualized and tailored to people. And effective person-centered care works to meet people where they're at, while also fostering resilience and recovery. And so this image that you see in front of you here came through my social media feed a while back. And I thought, man, that is the perfect example of person-centered care compared to traditional services. So the way that we used to do it is we used to tell you that you needed to meet us where we are at, which is usually way up here. And we would really provide a universal formula for success, one size fits all, and really expect people to be able to meet us where we are with that. And unfortunately, what we found over the decades is that wasn't terribly effective. What is much more effective is meeting a person where they are, tailoring interventions to where they are at that place, and then partnering with them to find small baby steps that they can take, small victories that will eventually snowball to build confidence, to gain more victories that will continue to propel them up that ladder of recovery. Okay. And so I just want to compare and contrast traditional services compared to person-centered care. So with traditional services, the way we used to do it, we place the authority with the provider. So we have the degrees, we have the licenses, so we know what's best for you, and you need to listen to us. Assumes that the providers know best. Expect total compliance. You need to do A, B, and C of what we say to get in recovery. And if that doesn't work for you, then that's on you. You must have failed and done something wrong, right? So we were actually inadvertently increasing feelings of shame. And expect total abstinence, this idea that it was all or nothing. You were either a chaotic user or you were fully abstinent. And what we know now is there's a whole spectrum that people fall in between on that. And again, with traditional services, we had this universal formula for success, rubber stamp it, come in, do A, B, C, D, and E as we talk about it. And again, you should find recovery. And then if you didn't find recovery, we would scratch our heads and think, that person probably just didn't want it enough, right? I'm old enough that I remember when some of this was still in play when I was just out of college. Contrast that to person-centered care. We're talking about a much different ball game. With person-centered care, we are attempting to meet the client where they are, not having them meet us where we are, but meet them where they are. And we're providing non-judgmental, compassionate care and consistent positive regard. And again, this targets the shame that really prevents so many people from getting into recovery and being able to access services. And again, it sees the client as the expert on themselves and the leader in the process. We are no longer in the driver's seat. They are in the driver's seat. Now we're in the passenger seat, simply offering support and guidance as needed and as they deem to be beneficial to them. And it defines success as any movement towards positive behavior change. So with traditional services, success was defined as total abstinence and total compliance. Person-centered care, success is any step in the right direction. For example, if I'm talking about somebody, a tobacco user who wants to give it up, if they smoke one less cigarette today, then that is a success I can cheerlead and a small baby step that we can then use to build feelings of self-efficacy, to build those victories on. Okay, it's not total abstinence, but it is a step in the right direction. And I know that when we nurture those baby steps, they grow into giant moon steps, right? Those giant leaps that we want to see. And it recognizes that people are doing the best that they know how. Injecting yourself with fentanyl may not seem like a loving act of self-care to most people, but if you have an opioid use disorder, it absolutely is. And so our job as providers is really to make sure that folks, when they know better, they do better. So let's find new ways of coping and working with them. Again, meeting them where they are to find better ways to powering them on their path to recovery. Christina, I see your face. Does that mean I'm running behind?
Well, we have about 5 minutes and we have a couple questions, but I want to make sure you get through. I think you just have another slide or two. I just wanted to note that
I think so too.
Yeah. So just wanted to let you know we do have a couple, but if we don't get to your questions, I will be following up with Elizabeth after to make sure that we can get answers for you, and we'll produce a highlight document for this with our questions and other things. So
absolutely. We'll work hard to make sure that gets answered. Good. And so this, always makes me think of Albert Einstein's quote, if you judge a fish by its ability to climb a tree, it will spend its whole life thinking it's stupid. And with traditional services, this is really what we set people up for, because we wanted them to meet us where we are. And when they weren't able to do that, we placed blame with them, which further entrenched those feelings of shame. And so this is why I'm so grateful that we are really starting to have a good understanding about how this stuff works now and are really dialing in more that person-centered care. So let's talk a little bit about why person-centered care works and is so effective. So as I was mentioning earlier, the ACE study found correlations between childhood trauma under the age of 18 and maladaptive health behaviors later in life, meaning people were more likely to smoke, they were more likely to have promiscuous sex, they're more likely to get addicted to alcohol, they're more likely to use drugs, they're more likely to gamble, that kind of thing. And the reason, potentially one of the reasons behind this, is that whenever we experience trauma, we inherently experience feelings of powerlessness, right? Something is being done to us over which we have no control. And we as human beings do not like feeling powerless. That is not a happy state for us. And so what normally happens, or organically happens, is we start to take ownership of the powerlessness. We start to believe that it's because of us the trauma is being done. If only we were somehow different, better, smarter, prettier, more obedient, more athletic, whatever the narrative is, then the trauma wouldn't happen to us. And again, we do that to alleviate feelings of powerlessness. But the problem with that, with this narrative that we develop, is it leads to a pervasive sense of internal shame, that there is something fundamentally wrong with me. That I'm not worthwhile, I'm not worth the air that I breathe, I'm not worth the space that I take up. And shame is one of the most toxic emotions that we have. It really doesn't serve a purpose for us. it really just works to incapacitate us. Because those thoughts are so invasive, this whole idea that, I'm not worthwhile, I'm worthless, I can't get this right, I'm stupid, I'll never figure it out. Those are all really heavy feelings to carry around. And so what happens is, to get away from those very painful emotions, we start engaging in addictive behavior, because an addictive behavior is a play at dopamine. Remember, dopamine's the feel-good neurotransmitter. And so when I can cultivate more dopamine, it makes me feel good in the moment. So I get some temporary relief. But what happens is, after that wears off, there's usually some sort of negative consequences that comes from the addictive behavior. Now, the addictive behavior could be substances, but it also could be sex, it could be gambling, it could be video games, it could be screen time. It's kind of pick your poison, right? And so when I engage in the addictive behavior, I get the temporary relief, but then there's some sort of negative consequences. So for substances, maybe I wake up with a hangover, maybe I wake up in jail, maybe I wake up and my family members are mad at me because we had a fight that I don't remember. Or if it's gambling or shopping, maybe I wake up and I've got these huge credit card bills. Or if it's food, maybe I'm watching the numbers on my scale go up and up and up. And those negative consequences then become their own source of shame. And how do we deal with shame? We engage in addictive behavior. And so we get into this cycle of shame and addiction that continues on until something interrupts that process. And so when we were working with more traditional services, again, expecting them to meet us where they are, and a lot of times setting up for failure, what we were doing was really further entrenching them into that cycle of shame and addiction. So contrast that to today with person-centered care, where we're working on providing non-judgmental, compassionate support, and consistent positive regard. We are actively targeting those feelings of shame. And as we work to target those feelings of shame, as we work to approve people who they are based on who they are, then what happens is those feelings of shame start to erode on their own. And so just an organic part of the process, as we start to approve people, the shame starts to loosen, and those compulsions to use and engage in addictive behavior start to loosen, which is why the compassionate care and the person-centered care is so absolutely powerful in this. And then the last thing I want to share with you guys are just the 4 major dimensions of the recovery process. These are the things that we want to make sure that we are addressing with folks with co-occurring disorders, because these are fundamental to their recovery. So it's health, making sure they're connected to good healthcare services for both their mental health and their physical health. Also teaching them how to engage in healthy choices and decisions that support emotional and physical well-being. It's also home, having a stable place to live. That's Maslow's hierarchy of needs. Remember, we've got to have the basic needs met before we can really focus on anything else. It's purpose. It's having a reason to roll out of bed in the morning. We all need a reason to get out of bed, otherwise we won't do it. And prior to getting into recovery, a lot of people, the reason for getting out of bed was their substance use disorder. So it's important that we find other meaningful activities to get them out of bed. And then lastly, community. Again, when we're talking about getting into recovery, a lot of time we're asking people to give up their current support system that may be a little bit more toxic, but we need to make sure we're being diligent about replacing those supports with healthier supports that they can depend on as they work on getting in recovery. And then just the last thing I will say today, in my view, our most important role is to believe in and see the potential. By the time people get to us, they're usually pretty down. Usually people don't come to us because they're having a good time. And so it's really important for us to be the holders of hope until people really can start to get their sea legs in recovery. And so it's really important that we be the cheerleaders and we hold the vision for them until they can get them themselves. All right.
Oh,
Perfect.
Elizabeth, I think we all wish we could spend the day with you. It has been so, we'll have you back. There's no question about that. I can tell from the chat and just hearing your
Good.
content. Thank you so much.
You
And,
bet.
you hit on such important points, and, seeing folks as not broken individuals, throwaway individuals, people who don't want their lives to be happier and healthier. I think it's so important that we do hold that positive regard. And, people just have been beaten down by life, and never
Right.
mind all these conditions. So I think just always understanding that people have been through things. It's not that they've just done bad things, and it's
Exactly.
it's really important that we keep ourselves compassionate. I just can't thank you enough today. I appreciate everyone staying a few minutes. We will do more on this topic and love to have you back. Thank you everyone for spending the time with us. We will get answers to the other questions that are remaining. And thank you so much for your time, Elizabeth. This has been really, really, really powerful. That video
Absolutely.
was unbelievable. So
Isn't it
we'll
good?
put that on the
It's one of my
resource as
favorites.
well. Yeah,
Yes.
really, really powerful.
Yes.
Thank you, everyone. Please take care of yourselves as you take care of others. Hold compassion for yourself as well as others. And we look forward to seeing you next time at any event, or be in touch with us. We'll hope to see you soon. Thank you so
Thanks
much,
all.
Elizabeth.
So good to be with you.
Thank you.